Thank you so much, and welcome everyone. Delighted that you could join us today. Again, I'm Barb Peaty, Executive Director of the Root Cause Coalition, and it's my great good fortune to have three members of the coalition with us today to talk about leveraging value through medically tailored meals. Just a little bit of background. The coalition was established 5 years ago to achieve health equity and address the social determinants of health. A cornerstone of that work has always been and will always continue to be addressing and dealing with food and nutrition insecurity. There is so much work being done in this area. I think you're going to learn a lot from each of the panelists today. We're delighted to have them as members of the coalition. The work that they do is exceptional, and I don't want to spend much more time than that other than to thank the Alliance to End Hunger for the opportunity to be in front of all of you today. We'd love to follow up with any questions at the end, and certainly even post this summit. We're delighted to answer any questions you might have and share more information about the Root Cause Coalition. So I'd like to get right into it. Our three guests today are Alissa Wassung, Senior Director of Policy and Planning at God's Love We Deliver; Cathryn, who is the Chair of the California Food as Medicine Coalition and the CEO of Ceres Community Project; and David B. Waters, who is the CEO of Community Servings. And again, I think you're going to find the information they have to be incredibly impactful, helpful, and able to be shared in your own communities. So with that, I'm going to turn it over to Alissa. Thank you.
Thank you so much, Barb, and thank you so much to the Alliance for welcoming this presentation today and our orientation toward creating equity. As Barb mentioned, my name is Alissa Wassung, and in addition to being the Senior Director of Policy and Planning at God's Love We Deliver, the non-sectarian, nonprofit, medically tailored meal provider for people living with severe illnesses in New York City, I'm also the chair of the Policy Committee for the Food is Medicine Coalition, or FIMIC, which is the National Coalition of Medically Tailored Food and Nutrition Providers across the country. We gather together to expand access to the high-quality, evidence-based intervention that is medically tailored meals through encouraging research, advocating for supportive policies, and promoting best practices. Right now, there are serious gaps in access to medically tailored meals across the country, and I'm encouraged to be presenting with my colleagues today on specific policies that are expanding access in our respective states. Next slide. So to begin our discussion, I think it's very important to ground our terms. Food is medicine, and it can be thought of as a spectrum of services from prevention to treatment. This pyramid that you see on the screen does not represent importance or the importance of each intervention, but rather the volume of individuals needing access to each intervention across our country. At the base, all people should have access to healthy food to prevent the development of chronic illnesses and to encourage health and flourishing. And as we progress to the top, food becomes more and more tailored to underlying or presenting conditions. In the top two tiers, you find food prescribed for an illness and designed for treatment. Medically tailored food is for those still able to shop and cook, and medically tailored home-delivered meals are for those that are limited in their activities of daily living, preventing them from shopping and cooking. All levels of this pyramid must be honored, supported, and funded. And at FIMIC, we participate deeply across the spectrum and believe to see a shift in our nation's health, we must work together. Today, we are going to focus on positive policy movement in that top tier. Next slide. So what is a medically tailored meal? Probably a new term for some. This particular slide is an example of the diets available at God's Love We Deliver in our intervention, but very similar to other Food is Medicine Coalition agencies. Medically tailored meals are delivered to individuals living with severe illness through a referral from a medical professional or healthcare plan. Meal plans are tailored to the medical needs of the recipient by a registered dietitian nutritionist, very important, and are designed to improve health outcomes, lower cost of care, and increase patient satisfaction. Some key aspects of the intervention are the involvement of a medical professional, so we're integrated with a clinical care continuum, the tailoring by that registered dietitian nutritionist, every client has a consultation, and then the layering of diets. For example, at God's Love We Deliver, almost 50% of our clients are living with 4 or more illnesses at one time. And our registered dietitians and chefs must be able to layer restrictions to provide the right food for this complex medical situation. The clinical committee of the Food as Medicine Coalition, composed of RDNs across the country, went through a rigorous process to develop the nutrition standards that preserve the quality of the intervention and its evidence-based nature. Ongoing nutrition counseling happens throughout someone's time on program and is key to the intervention, as is food safe home delivery. But most importantly, our food is delicious. Appetite is often the first thing to go when someone is severely ill, and our food is medicine, but it doesn't have to taste like it. Next slide. It is that quality that produces some of the incredible peer-reviewed research outcomes coming out of FMIC agencies. On this slide, you see a 16% net healthcare cost savings, 50% reduction in hospitalizations, a greater chance of going home rather than a long-term care facility after an inpatient hospitalization. These are incredible outcomes. So the key takeaway here is that medically tailored meals work, and delivered in the way that we provide them, they really move the needle on key healthcare outcomes. And yet, there is very little funding for this intervention. Next slide. So there is currently no dedicated federal funding for medically tailored meals, save for those living with HIV. And that's really delivered through the Ryan White HIV/AIDS program. But this support varies widely across the country. It's not uniform, and it still doesn't cover all those who come to us in need who are living with HIV. In fact, most Food as Medicine Coalition agencies raise the majority of their budgets yearly through philanthropy, almost the opposite of other anti-hunger providers. There is piecemeal and optional coverage for severely ill individuals in Medicaid and also Medicare. Some of those pilots that prove our value proposition will be spoken about today, but again, that is not broad-based coverage and leaves large gaps of coverage across the country. So to correct this, members of the bipartisan Food as Medicine Working Group of the House Hunger Caucus introduced HR 6774, or the Medically Tailored Home Delivered Meal Demonstration Pilot Act of 2020. Bit of a mouthful, but intentionally named. This demonstration pilot would rigorously evaluate the medically tailored meal intervention in a Medicare fee-for-service population. That population currently has no access to medically tailored meals through their insurance. The pilot would operate geographically diverse in 10 states over 3 years, but most importantly, if successful, the pilot could be expanded further into Medicare, increasing access to this life-saving intervention. The bill hasn't passed, but we're encouraged by the bipartisan support, and we're really looking forward to supporting its eventual passage. Next slide. Just a bit of a note before I go over to New York State. A bit about our response as a coalition during this pandemic. It is another pandemic we have responded to as a nationwide coalition, the HIV/AIDS pandemic being the first. God's Love, as many of our other FMIC agencies have been, open and delivering as an essential service provider throughout the pandemic. We're seeing unprecedented demand for our services as both our current clients need more support and the pandemic has created new clients that either need to shelter at home or are being discharged from the hospital. To give you a sense, God's Love has brought 3,200 clients on during this time, which is a 30% increase in our services. And overall, we're cooking and home delivering 50,000 meals a week. Medically tailored meals, as you saw, prevent some of the key outcomes that we're trying to avoid during this pandemic. And we've all pivoted our operations for safety with contactless delivery and masks and social distancing. And this has greatly, significantly increased costs. And so the takeaway for the future, which is I think the direction that we're moving in with this presentation, is to not lose the learning of this time. How do we move toward a more equitable system now that COVID has exposed the fragility of our nutrition safety net and the lack of connectedness from the clinical side to the community? And really that medically tailored meals should be a reimbursable healthcare service, especially within Medicare and Medicaid. So with that foundation, I'm going to move us into our state-based discussion, and I'll spend a little bit of time on New York State before I turn it over to my colleague, Cathryn from California. Next slide. So I am so excited to talk to you about our multifaceted policy interventions here in New York State. To frame out our particular program, God's Love was founded at the height of the AIDS pandemic, much like many other FIMIC agencies, 35 years ago. And we now cook and home deliver 2.3 million nutritious meals each year to 9,600 clients and their children and senior caregivers. And we do this with the help of 17,000 volunteers. We've been pleased to be able to keep our volunteer opportunities open and safe during this pandemic, and we couldn't do what we do without our volunteers. Our clients live with over 200 different diagnoses, so from HIV/AIDS to cardiovascular disease to cancer and renal failure, and we deliver throughout the New York metro region and are moving statewide. Next slide. Our state goal is systems change to ensure that the medically tailored meal intervention is part of the continuum of care, that it is broadly accessible to those who need it, and that it is of the highest quality. Again, emphasizing that quality and evidence-based nature. To do that, we have innovated with a number of partners in our state healthcare structure. And I think what you're going to find with our presentations today from Massachusetts, California, and New York is that state healthcare structures vary widely, and we've all found paths forward to increase access. We're really going to be concerned today with the payer and the government portion of our work, but I wanted to orient you to what we do more broadly. On the left, the payer side is a focus on public funding streams that involve insurance companies. Most of our clients are eligible for Medicaid or Medicare, and we want to partner more closely with those entities because it helps also coordinate care. So really, this is leveraging current policy innovations to encourage those plans to contract with us to provide medically tailored meals. In the center, we work with clinical providers to assess, refer, and evaluate our intervention. We've worked extensively with delivery system reform projects in our state, as well as with technologies that facilitate social determinants of health referrals like Unite Us, Now POW, and Aunt Bertha, Now Find Help. On the right-hand side, we have a broader-based strategy to change policies and allow payers and community-based organizations to take advantage of a benefit. And this is where I'll be talking about our legislation introduction and state-funded pilots. Next slide. I will focus mostly on Medicaid in our state, though there are some Medicare pilots that we've been considering. We are unique in New York State. Medically tailored meals are actually a covered benefit in our Medicaid program for a small subportion of our Medicaid clients. So high need patients that receive their insurance through managed long-term care. We've been contracting in this area for over 15 years. We have about 20 plans that we contract with, and we serve more than 20% of our clients through this funding stream. But that only covers enrollees that are part of that portion of Medicaid and leaves the largest population in Medicaid who look a lot like managed long-term care enrollees without any access to medically tailored meals. So we're trying to change that. On the right-hand side, we've got 3 different initiatives that we have implemented to expand access. The first, legislation would allow coverage of medically tailored meals for all those who need it in Medicaid. This is a broad-based change that would somewhat eliminate the need for piecemeal funding streams. On our journey toward that reality, we have leveraged value-based payment and in lieu of services to policies that are state-based to increase access. Value-based payment really incentivizes the incorporation of social determinants of health projects into risk-bearing insurance contracts. And in lieu of services is an option to offer one service instead of, or in lieu of, another service that's already a covered benefit. Next slide. So first, let's talk about our legislation. Very exciting and really a result of our ongoing effort to educate legislators on the effectiveness of our program. This would make medically tailored meals a broadly accessible benefit in all of Medicaid for those who qualify. In year 1 and 2, we had many champions. We executed a cost-benefit analysis that really contextualized what we could expect if the benefit were introduced. We did visits. We had the tremendous good fortune to have both an Assembly and a Senate bill introduced to support this expansion. and went through the budget process and became part of the One House budget recommendations for both houses. While we didn't make it into the final budget, a side letter post-budget was issued encouraging further exploration of this expansion. In year 3, which was this year, we experienced an extremely austere budget season. We have one of the largest Medicaid budgets in the country. There were tremendous shortfalls, and so they were looking for cost-saving measures. Our pilot floated to the top and was included in the budget and will now be implemented in 3 sites across the state with a rigorous evaluation component. We don't yet know exactly what that will look like, but it's a huge success, and the legislation for the broad-based coverage is still on the table for future legislative sessions. Next slide. And then on to leveraging the drive toward value. We've talked a lot about value. Really, this is the push to reimburse for results, not the amount of service or healthcare insurance billing that happens in healthcare. New York State has an incredibly broad roadmap, and part of it focused on social determinants of health. We're the first state to have a social determinants of health bureau in our DOH. And it was a requirement that certain risk-based Medicaid insurance contracts include both a community-based organization in contracting and a social determinant of health project. We fulfill both and have had some really incredible success with a lot of hard work in establishing 6 mainstream Medicaid projects and 2 projects that really enhance the nutrition component of our existing benefit in managed long-term care. So really innovative, and we're excited to see how that evaluation comes to pass. Lastly, another option in our mainstream coverage is that plans can apply to the state to replace a covered benefit with an uncovered benefit if cost parity can be achieved, so it can't cost any more. Once approved by the state, other plans can then utilize that same in lieu of services benefit. So we chose to make the case for replacing meal preparation done by a home health aide with a medically tailored meal designed for a member. And we demonstrated cost parity, and after 3 years of incredibly careful planning, we hit go on November 1st with our partner immediacare. We implemented a much more rigorous evaluation than required, and so we're really excited to see how those qualitative outcomes advance. Next slide. So we've come to the end of my portion. This is my favorite subject to talk about, so I hope you'll contact me if you have any questions about Medicaid policy in New York State or the federal landscape. I'm excited to see states moving in a positive direction. More evidence means more weight to the national conversation about expanding access to this benefit and achieving health equity. And I have included some research on the next few slides that I'm not going to go through, but please utilize it as a starting place for exploration. And with that, I'm going to hand it over to Cathryn. Thanks, everyone.
Thanks so much, Alissa, for laying out such a good foundation for David and I. And we can go, I think there's a couple of slides to fast forward through here, and then my slide will be, go to the next slide and the next slide. Thank you so much. So I'm Cathryn Couch. I'm the chair this year for the California Food is Medicine Coalition, and also the CEO for Ceres Community Project. And CalFEMIC is a subset of the Food is Medicine Coalition nationally that Alissa was talking about. We're a group of 6 medically tailored meal providers across California that had been working together, but really came together in 2017 around the project that I'm going to describe. Ceres, the organization that I founded and lead, is based in Northern California. We currently cover 2 counties and are looking at an expansion into parts of Northern California that are really uncovered in terms of services because of the very rural nature of that part of the state. So you can go to the next slide. I'm going to talk about a legislative strategy that we used in California and that frankly we kind of stumbled into. The gentleman that you're seeing on the slide is our state senator, Mike McGuire. He's been a longtime champion of ours, and this is a picture taken in 2016 when he emceed our annual fundraising gala. And I had come back from the Food is Medicine Coalition the week before this. And at that dinner, I spoke with Mike about wanting to sit down with him and really talk about the value of medically tailored meals and really starting to understand our work as a healthcare intervention. And so he and I sat down in November of 2016 and really kind of engaged in a conversation about what medically tailored meals were and how they could be valuable to the state. And I'll be honest, it was Mike that came up with the idea of doing a statewide study in California. And that's why it is so critically important to find champions in this work. So he and I, between November and January of 2017, framed out this idea of asking the state Senate and then the state Assembly to fund a statewide pilot in California in the Medicaid system to look at the value of medically tailored meals. And, you know, we were successful for a number of reasons that I think I want to point to here. I want to say too that this is really a testament to the importance of being in conversation with your state elected officials and really educating them about what medically tailored meals and other food interventions are and why they're so critically important to the populations that you serve and that they care about. This whole thing really started with this conversation with Mike. So we framed out this idea of asking the legislature for funding to do it. It started as a 3-year study. It's ending up being a 4-year study. And Mike was really the champion for getting this across the bridge. So the other things that were really important for our success in California were that we pulled together a coalition of agencies. And I'll show you in a minute, but there are 6 of us. We cover about 48% of the state population. And we cover some of the largest and most populated districts in the state. What that means is there are a lot of elected officials that are in our districts and a lot of elected officials that we had existing relationships with. We had an initial meeting in Mike's office with the Senate Budget Subcommittee on Health and Human Services in February of 2017 and received not positive encouragement, I would say, around the likelihood that we would be able to get something accomplished. The budget cycle has to be completed by the end of June, so we were late to the party. But we got to work. The 6 leaders in the coalition got to work talking with our elected officials across our districts, and we're successful in getting this legislation passed. The other thing that we did is we took the data from some of the published studies that Alissa had talked about, and we basically modeled out what that would mean for 4 different diagnoses that were really critical in California. So congestive heart failure, COPD, cancer, and diabetes. And we were able to show elected officials that a $6 million investment would likely return something like 13 to 15 million for the state. So we made it really easy for them to advance this legislation. And California was, I would say, at that time also in a budget surplus. So that also made it a little bit easier. Next slide. So here's what we're doing. We received $6 million from the California legislature in 2017 to do this 4-year pilot. The funding was part of the Medicaid authorization for that year, and we've had it reauthorized every year. The project is overseen by California's Department of Healthcare Services, which is the oversight body for California's Medicaid system, which we call Medi-Cal. The funding allowed us to serve at least 1,000 patients, and it's likely going to be more like 1,400 patients across our 7 counties. It includes 21 meals a week for 12 weeks, and with 3 to 4 visits with a registered dietitian doing medical nutrition therapy. And Department of Healthcare Services actually picked the diagnosis. They selected congestive heart failure, which, as many of you know, is the #1 readmission rate diagnosis for readmission in California's system and many other places as well. So this is the population we're serving and the intervention that we aligned on across the different agencies. Go ahead and let's look at the next slide. So here's where we are. We are, again, 6 agencies. We cover 7 counties, about 48% of the state population, but as you can see, we're primarily coastal. And we are looking now at how we will cover most of the rest of the state, but particularly the Central Valley area of California. Next slide. So what have we done so far? We have now provided 148,000 meals, probably close to 150,000 now, almost 1,400 medical nutrition therapy visits and about 800 clients. We found that we have about 2/3 of the clients that are completing the full intervention, and we are tracking the self-report data from the clients that we're serving and showing dramatically lower 30 and 90-day readmission rates for that population. Next slide. So what's been the value? I just want to talk about evaluation first. So the evaluation for this project will be done by an outside evaluator. It's going to be Mathematica, which some of you may be familiar with, or a national health evaluation firm. They were selected by Department of Healthcare Services, and DHCS will be overseeing the evaluation. They have begun that process, really gathering some qualitative information, interviews with all of the implementation agencies. They are interviewing patients who've received the intervention, gathering that kind of data. When we complete the study at the end of 2021, they will be working in the Medi-Cal claims database and looking at all of the data for the patients we served compared to a control group of patients who did not receive the intervention. They'll be looking at data prior to the intervention, during, and then for 6 to 12 months after the intervention. And they'll be looking at utilization data and then doing a cost analysis to see does the intervention prove cost effective, as well as improving health outcome data. So we're really excited about that, but it will be probably another 2 years before that data is available. Next slide. So I think what's really important here is that doing this work with our elected officials and getting this pilot funded has really opened tremendous doors across California. And I would say that the California Food as Medicine Coalition and our individual agencies are really in a markedly different space now as we work on changing policy in California. One of the things that's come out of this is, Alissa referred earlier to the in lieu of service benefit. California is in the process of applying for our next 5-year waiver from Medicaid called CalAIM that will go into effect in January 2022. And because of the work that we've been doing with DHCS, they included as an ILOS benefit home delivered meals at discharge from the hospital for any Medicaid member, and medically tailored meals for 8 different diagnoses, including pregnant moms. And so beginning in 2022, that structural benefit will be available in California. And we are now doing significant work to educate plans across the state about the value of the benefit and really encouraging plans to lean in and to start to offer that benefit for specific populations starting in 2022. Because of the work that we were doing, Central California Alliance for Health, one of the Medicaid plans in the central part of the state, who had already been doing quite a bit of work in the food space, defined their own pilot, and they just completed that. It was a 2-year pilot providing very similar intervention, 12 weeks of 14 meals a week for Medicaid members being discharged from the hospital. They defined it 4 different diagnoses. So what's great is it includes diagnoses beyond CHF. And they have just done the analysis on that and found it so successful that they have now made it a permanent benefit in their plan. And the highlight of it is their analysis showed that they saved $3.60 for every dollar they spent on the benefit. So that's tremendous outcome. We are also doing a number of other pilots with Anthem, Blue Shield Promise, some work with Kaiser, and some of the other plans in California. And part of our work statewide is to pull those plans together. We'll be doing probably a webinar in Q1 of 2021 to have those plans share the data that they're gathering. And again, building this broad-based understanding of the value of medically tailored meals across the local area, health plans in California, the Medicaid plans, but also the private insurers as well. We also have been able to do significant work at the state level now. We just recently have convened a statewide coalition of all of the nutrition service providers and beginning to really work with them to begin to advocate for what is a comprehensive approach to nutrition mean for the state. We're doing a lot of work with the aging population. California has just completed about an 18-month project to develop a master plan on aging for the state of California, and we were able to significantly improve the inclusion of nutrition security in that plan, and are working on laying out some other policy wins related to the master plan on aging and working with the senior population. Next slide, please. So lessons learned, you know, doing this work, I think, has really provided enormous visibility and credibility for the conversation about medically tailored meals. We've been able to open doors that we hadn't opened before and really leverage a lot of PR and visibility for the work. And that, of course, is really instrumental in moving the policy conversations forward. I would also say that it takes enormous patience and perseverance to do this work. My first conversation with Senator McGuire was in 2016, and we will not have data for another 2 years. So that will be a 6-year process to build the data on this. And so you just have to have that long-term view, I think, here. Really important to find champions. So we, along with Senator McGuire, we have now created a statewide medical advisory council for the California Food as Medicine Coalition. It includes senior leaders at a number of the largest Medicaid plans in the state, as well as researchers and others. We're actively engaging them in our policy work as leaders in the field, and that is really, really helpful. And then I think continue to tell stories. I mean, we are actively engaging continually with our policymakers at the state level with the plans, sharing data, sharing stories. The data that I shared from Central California Alliance for Health is their 2-year study. I have actively shared that with a wide array of policymakers in the state to ensure that we're continuing to forward an understanding of the value of medically tailored meals. And all of that, you know, it's a long, slow, steady process, but all of that really, truly does make a difference. And I think we're a good example of starting really from from nothing 4 years ago, and really have seen significant increase in the adoption of medically tailored meals. And now with the Medicaid advance in 2022, we have a foundation now for really broadly expanding the work in California. Next slide. Like Alissa, we are very, very happy to support conversations with any of you around the country who are engaged in this work. If you want to know more about what we did in California with some of the other work that we're doing, please do reach out. I've included Ann Thrupp, who's the director of the California Food as Medicine Coalition, and she and I are happy to talk with you if you want to know more. And again, thanks so much to the Alliance for having us. And I'm going to pass it on to my colleague, David Waters.
Thank you, Cathryn. And again, thank you to the Alliance for hosting us and to Root Cause. Good afternoon, everybody. I'm the CEO of Community Servings in Boston. We serve critically ill and chronically ill patients all across Massachusetts. Next slide, please. Like Ceres and God's Love, we are a medically tailored meal program primarily. That's our central focus and grew out of the HIV world. In terms of scale, we are sort of mid-sized between Ceres and God's Love. God's Love is probably twice the size of Community Servings in terms of budget. We provide this year about 800,000 meals with about a $10 million budget, and we cover the entire state of Massachusetts, serving more than 2,300 people a year. One of the things that I just wanted to touch on too, those research slides that were quickly passed over between Alissa and Cathryn, they will be in the slide deck. 3 of the most significant research studies around medically tailored meals, we were lucky enough to host at Community Servings in partnership with Dr. Seth Berkowitz. If you don't know Dr. Berkowitz's work, I suggest looking into it. He's one of 2 or 3 of the most significant researchers in this field, and is based at the University of North Carolina. In partnership with Dr. Berkowitz, we just launched our very first NIH study. It's an R01 study that will look at, it's an RCT study looking at the impact of medically tailored meals versus other interventions for patients with type 2 diabetes. It's a 5-year study, which we're really excited about. Next slide. One of the 2 pieces of the story that I wanted to tell you today, the first is about flexible services, and the second is about our statewide coalition. The largest demonstration project, I believe, in the country around medically tailored meals and other food as medicine interventions is happening here in Massachusetts. Massachusetts Medicaid operation is called Mass Health, and they got an 1115 waiver from the feds through Medicaid to do a 3-year study, $149 million on what's called flexible services, specifically funding Medicaid ACOs, there are 17 in Massachusetts, to provide social determinants of health, specifically housing tenancy and nutrition, and measure the impact with the intent to see which has the best outcomes and the best savings, such that these ACOs might be willing to pay for it themselves in the future. So significant investment, but the intent is that ultimately it would sit on the shoulders of the ACOs. However, what's exciting about it is that during the 3 years, the monies, the $149 million, cannot be spent on healthcare, nor can it be spent on administrative costs. So it has to flow directly through to what in this bill they call social service agencies, or SSOs, and we'll see more about that in a second. It's designed to address the health-related social needs of ACO patients, who are the most complex patients in the system. And the investment is meant ultimately to demonstrate a reduction in the ACO's total cost of care. So getting good data will be key to this. Next slide. There are 45 programs within flexible services for 30 social service organizations across Massachusetts. 20 of those programs are nutrition-based as opposed to housing-based, and are going to 9 different SSOs, a subset of the 30. And community servings is the largest recipient of contracts. So as one agency, we have 8 Medicaid contracts, which I think we think of food interventions in the context of healthcare holistically across that pyramid that Alissa illustrated at the beginning of our conversation. But there is great interest specifically in medically tailored meals because it has stronger data, and it is more, it is definitely downstream and more of a treatment intervention rather than a prevention intervention. So you can see cost savings in a very short time, typically 3 months, unlike changing a child's diet, hoping that it will improve their health as an adult, that kind of thing. So in this first year, there's 9.9 million budgeted for nutrition programs. So pretty big program, and we're very excited about it. Next slide. Similar to Ceres, well, somewhat similar to Ceres, this is a weekly delivery. In Ceres' case, it's 21 meals across California. Per week. In our case, it's 10 meals in this program, 5 lunches and 5 dinners with snacks, milk, etc. And the intervention generally is a 6-month intervention. So when a client is referred through the Mass Health ACO, they're going to be getting meals for 6 months. And they're also going to be receiving support from our RDNs. So assessments initially, counseling, education, etc., in the 6 months while they're with us. And somebody asked earlier, these meals are all frozen meals generally. Some of them are chilled, but not hot meals delivered to the patient. And as I also mentioned, we're statewide, so we're going to people's homes once a week, or we're shipping to them if we can't reach them within an 8-hour workday. Next slide. This gives you a sense of the program growth since April. Ironically, or unfortunately, the launch of this program coincided with COVID, just as the epidemic was getting to its worst in Massachusetts. So we grew very quickly. You can see we're We're level here at 3,200 meals, which translates roughly to 320 clients, and it has been relatively stable since July. We expect in the new budget year, which will start January 1st, that we'll see another big jump because these programs in the first partial year had a smaller budget available. We have several of the 8 contracts that intend to double. Counter to that is that some of them referred COVID patients in this first year, which hopefully will not be the case next year. So they earmarked some of those flex dollars specifically to feed COVID, to address both the illness, the isolation, and the food insecurity that's rampant in the pandemic. One of the interesting things in terms of challenges that this represents is with 8 different contracts, you have 8 different healthcare organizations referring, and they're all using different referral platforms. So most of them are using a secure email. Some of them are using programs like Aunt Bertha, et cetera. But none of those talk directly to our own CRM, our client database. So the initial challenge is a huge data entry challenge if you're getting 40, 50 people referred per week for our team to be able to data enter them before they get them into the system and do their assessments. So we have built a portal. We run off of Salesforce CRM. We have built a portal that works with about 4 out of our 8 contracts initially, and we're customizing beyond that to get each of them a more efficient way to bring those referrals directly into our system. Also, to be able to work with all of these healthcare organizations, we had to strengthen our HIPAA and data security significantly. We're now deemed in Boston as what's called a first-tier downstream related entity, which means that our data security mirrors that of our healthcare partners, which is key. Next slide. So the most important part of this will ultimately be evaluation, and yet getting the program up at the state level with the 17 ACOs has been so cumbersome that I will say that they have not put a lot of work yet into their evaluation plans. They will have the data, but they haven't exactly defined beyond the obvious what they'll be measuring for. So we're trying to encourage each of them to work directly with us on evaluation for our intervention and building off the research that we've already published. As part of that, we've formed a partnership with the Tufts Friedman School of Nutrition and University of North Carolina School of Medicine, Dr. Berkowitz, to develop our own evaluation consortium that is working initially with 4 out of our 8 ACO partners and hopefully more to delve even deeper and perhaps collect more data from patients to have a richer collection of evaluation results at the end, which I think will be really important. Next slide, please. So the second story I want to tell you about is a really successful advocacy story that we have done here in Boston in partnership with the Center for Health Law and Policy Intervention at Harvard Law School. They're referred to as CHLP based on their acronym. And they are close partners of all of the food as medicine programs, but because they are our next door neighbors here in Boston and Cambridge, we work particularly well with them. And so together we set out to develop what we called the Food as Medicine Massachusetts statewide plan. We brought together 195 organizations or 195 members representing a wide variety of community-based organizations, healthcare providers, government, academic, et cetera, to map out what are the current food as medicine interventions, to define what those interventions mean, because as you probably see in your own communities, people use terms interchangeably and not always clearly. So what does it really mean to be a medically tailored meal provider versus providing a medically tailored food box or veggie prescription, et cetera? With that statewide plan, it took about a year and a half. It's the first in the country. The coalition then broke up into 3 task forces that have continued to work over the next 2 years since that initial plan. One is focused on nutrition education and referrals from providers, led by our state physicians group, Mass Medical Society. One based on CBOs, which we lead with our local Feeding America Greater Boston Food Bank, and a third around research led by Children's Health Watch and CHILPI. Each of them is building a really solid network. One of the things they did was to map across the state overlays of food insecurity, lack of transportation, diagnoses of chronic illnesses, et cetera, to really target where the greatest need is for one intervention or another. You know, there needs to be a veggie prescription program in the Northeast quadrant. There needs to be an MTM provider, et cetera. Next slide. One of the key exciting pieces that has come out of this is bringing the statewide plan to the state legislature and doing a presentation to them, to the Joint Committees on Public Health and Healthcare Finance, which ultimately led to state legislation that mirrors the federal legislation that Alissa mentioned. Congressman McGovern has put forth around the federal legislation. We have similar legislation pending at the state level, which we not sure it's going to move this year, although we've had good interest, but we hope we'll move next year, depending on budget constraints related to the pandemic. Next slide. So just quickly, some of the lessons that I think are relevant for each of you is to know your research, not necessarily your own research, but our research or someone else's research. Know it well enough to be able to bring it as part of your advocacy message, and to really emphasize the impact that food insecurity has on the healthcare system. We all know it intuitively based on our work, but really trying to quantify that for your legislature, for your advocacy audience, working closely with your allies. You know, we've developed a wonderful relationship with the Mass Physicians Association, Mass Medical Society, other groups that we would never have dreamed of before. Developing friendships and relationships on the legislative side and the executive side of government. And advocating particular need, as we all know, in the midst of the pandemic and the economic crisis, the food insecurity has skyrocketed, and there's more interest in our work. So you really have to jump in right now and be advocating for this. Ultimately, it all comes down to me as telling your story and using as much data and as many different opportunities to tell that. And then the last thing I'll mention is that if some of you feel like you're doing something very similar to what we're doing, or you're one step away from what we might call medically tailored meals, the Food is Medicine Coalition, in partnership with Community Servings and God's Love and several other partners, launched a Food is Medicine Accelerator, which essentially teaches what we do over a one-year curriculum to other nonprofit meals programs who are interested in accessing healthcare contracts and ready to reach the level of rigor that comes with these multi-layered, customized prescribed diets. So reach out to any of us if you're interested in learning more about that. Like my peers, this is my favorite topic, and I'm delighted to talk to you today and would be happy to hear from you again. And now I think we can move to questions.
Great. If the panelists want to turn on their cameras, Barb, I'll kick it to you.
Great, thank you. And Alissa, Cathryn, and David, thank you. What a wealth of information. Truly amazing work that all three of your organizations do, that the Food as Medicine Coalition does. We're so honored to have you as part of our voice at the Root Cause Coalition. Again, by way of background, our coalition founded 5 years ago with food and nutrition insecurity as a cornerstone. And our three pillars are advocacy, education, and research. But I think as we hear today, there really is a critical need to move policy. The examples that you've heard today are amazing and can be scaled and replicated, and we learn from them. But ultimately, if we want to really move that needle in a far direction the way it needs to, it's going to take policy. We had a members call with Congressman McGovern a few weeks ago, and one of the things he said to our members was, we don't want to go back to normal. I think this pandemic has us all aching for what was behind us, but I think everyone on this panel, in addition to all of you participating today, know that what was before COVID was not acceptable either. And so it's up to all of us to not go back to quote unquote normal, but to make it better. And this pandemic has really laid bare the issues that are in front of us, that were in front of us, quite honestly, for a long time beforehand. We just now have an opportunity, with everybody understanding how tenuous and stretched that security net is. So we welcome your inquiries and participation in Root Cause Coalition. I want to thank Eric and Minerva and Danielle and Nathan at the Alliance to End Hunger. You're phenomenal partners, also a member of the coalition. And I think all believe our best days can always be in front of us, and working together, that's what we're going to be able to achieve. And would love to entertain the questions now. And Kristen, I'll let you kind of field those from the chat room. So thank you all.
Great. We had a couple of folks who were wondering about what you were finding is the average cost per meal.
So I can start, and then David and Cathryn, you can take over. I think that's the $1 million question, right? And it's a bit difficult to answer because the costs vary by program, by geography, by model. Some interventions include our RDNs, whereas with others, we partner with the institution's RDNs. Some interventions may include additional nutrition follow-up or home visits. So each cost or healthcare partnership is really tailored to that partner, and our ability to be flexible in that area has been key to our success, actually. There's several public interventions that do look at costs. Some of the studies that I mentioned in those 3 slides that we didn't deal with look at cost savings net for medically tailored meals. And I wanted to mention another resource just to look at the cost savings question. You can look at the Commonwealth Fund's return on investment calculator, and it's a tool where you as a nutrition provider and your healthcare partner can input your own costs to kind of come up with a cost savings estimate together. So that's a really important question, and it's sort of something that in our experience develops by partnership. Cathryn, David, do you want to?
Yeah, I would just add to that. Thanks, Alissa. The other thing I would add to that is that generally speaking, medically tailored meal programs are more expensive interventions because they're providing nutrition counseling, because the layering of diets, the focus on scratch cooking, lack of processed foods. So we are probably the most expensive of food insecurity interventions, but that's balanced with the cost savings in healthcare. So I generally say that if we can prevent, if our medical diets can prevent 1 night in the hospital, we save the system enough money to feed somebody for 6 months. So it's very cost effective in the context of healthcare, but as an intervention, it's more than just the meal.
Thanks. The only thing that I would add, because I'm in these conversations a lot, and I think one of the things that I think we all need to do is to counter the assumption that food should be cheap, which is a really interesting one. I think many of the partners that we talk to want to know, like, what's the cheapest intervention that they can get. And when you compare the cost of feeding someone a really high quality diet with RDN support compared to, as David said, many of the costs in healthcare, we have to kind of shift our thinking here and be willing to spend on a quality food intervention because of the value that it's going to bring instead of trying to have the conversation about how cheap can we get it. So there's a general conversation in our country, I think, about the idea that food should be cheap. And I think it's all of us who are working in the food space want to be really empowered to challenge that idea, because cheap food has often or always has costs that we're not paying for at the grocery store, at the point of providing it, but other costs that we need to take into account.
Great. There's a couple of folks wondering about food as medicine programs being culturally appropriate and where there's direct collaboration with diverse communities.
I'll jump in first on that, and Alissa and Cathryn can join. Many of us know, for instance, Meals on Wheels programs that are focused on, say, Russian immigrants or Haitian immigrants or something like that. Some direct ethnic diets. Because medically tailored meal programs are providing medical diets, we don't generally also provide ethnic diets. However, the two things that we all generally do is to really look for recipes amongst the cultures that we do serve. So here in Boston, it's primarily African American, Latinx, and Haitian. So our cooks are our chefs are from those communities, those cultures. They're bringing recipes from home. So you can't be on a, say, purely Haitian diet, but you will see those dishes in the course of your meal plan. The second thing is that we do, out of food preferences, control for many of those things. So in our kitchen, for instance, we don't serve pork to satisfy a Muslim or a Jewish population. We don't serve shellfish. People can choose whether they get red meat or not, et cetera. So some of it, while we can't do a strictly one culture, we weave them all in and try to respect the restrictions.
Great answer. I agree, David. I don't have anything else to add. And Alissa, I thought your answer in the chat was really
I answered in the chat.
Well said as well. Yeah.
Yep.
Great. We have go ahead. Sorry.
Just one last thing. Also, because we do not have, not to bring it back to policy again, because we are not primarily funded through government contracts, it also allows us a lot of flexibility with nutrition science, because nutrition science is evolving maybe faster than government regulations are. And so I noticed the point about goat's milk or other alternatives or plant-based diets or plant-based options. We can make those changes a lot faster because we are not answering to certain, government dietetic standards for certain populations. Not that we don't abide by them or go above and beyond them, but we have some more flexibility in that area to really stay step by step with nutrition science.
I wanted to briefly touch on Karen's question about the pediatric population, because I think it's particularly interesting. Traditionally, medically tailored meals programs were focused more on adults. Most of us feed not just the person who's sick, but also any dependents as well as a caregiver. So we've been feeding a pediatric population for a long time, but not generally with their own medical diet. However, with these new insurance contracts, that is shifting because something like 40 to 50% of Medicaid patients are children. So here in Boston, we've just launched 2 different pediatric diets specific for, broadly speaking, being overweight or underweight as a broad classification. And we're really excited to be beginning to market those, as well as a new diet for at-risk pregnancies.
And to piggyback on that, it's not just for insurance contracts. Remember, the majority of our populations are funded through philanthropy. And so we have a really interesting and wonderful project with Ronald McDonald House here in New York City, feeding pediatric patients in Ronald McDonald House, and also supporting families through their treatment. So I second that, David.
Great, thank you. There are, of course, more questions here than we have time for. They've provided, our great panelists today have provided their contact information. A huge thank you to all of you for sharing your expertise today. Please keep those questions coming and the conversation going in Whova. You can access it at any time by clicking View Session from the agenda, and there's actually a chat and a Q&A function in there that you can continue the conversation on this topic. Coming up next is a panel discussion focused on how corporations respond to hunger during COVID, and we're looking forward to seeing you all there. Have a great afternoon.
Thank you.
So
Thank
much.
you.
Thank you so much.
Thanks, everybody.
Take care, everyone. Be safe.